Morning, morning everyone. Morning Webbo. Happy Anatomy Day. It is freezing here. Yeah, absolutely freezing. I've just moved into a kind of new. I say office. It's not really an office. It's a bit of a converted garage, and it is cold. But I've hooked up. Obviously, no affiliation to these. There are other internet-based plugs available, but they're Hue system. So I've got a heater connected to the plug, and now set automatically to warm up this really cold space a couple of hours before I get here. So it's quite pleasant today. So let's get you going. Let's just make sure everything's looking good. So last week we looked at the bones and bony landmarks of the hip and the pelvis, and a few. I don't know whether these things are controversial anymore. I'm hoping they're not, because the message has been going around for quite some time. But I think there are still quite a few people teaching about postural anomalies and all that kind of stuff. And the differences in anatomy with the ASIS and PSIS and the iliac crests and all of those kind of things. So hopefully the message is getting out there. If you do chat to someone where they're still going on about that kind of stuff, just please share the videos. That would be really good, because the more and more we educate, even like patients as well, we need to educate patients on it so that they don't fall down the trap either. I think we still are losing the battle, Tris. Okay, because you kind of think, oh yeah, everybody knows this stuff because you're in your own little echo chamber when everybody's saying the same thing and going, yeah, and you're going, this is boring because we know it. But then actually, I meet people who should know better and they don't know it, and it's quite astounding, really, because I've been going on about it for probably about 10 years. So it's definitely not new stuff. But there we go. Morning, Steph. Good morning. Good to see you there. And the usual Triss is in. Good to see you, Triss. Right, let's get you going on this. Get rid of that. So, we're looking at connective tissue today. So I've labelled it that, bit of a catch-all term for all of the kind of passive structures around this area. Should hopefully get it done in today's session. There's not too much to cover, and then we're on to the muscles and tendons, and that will probably take a bit of time because there is a lot going on, hip and pelvis. And then I remember a couple of years ago did a whole session just on pelvic floor stuff, so we'll go through that region too. So hip and pelvis is the main focus today. So the hip joint, sacroiliac joint, all that kind of stuff, and then we'll have a look at the pelvic floor on another session. So ligaments of the pelvis, first of all, hip and pelvis. We'll have a look at, and these are the main ones. Just grab my arrow here. So just give you an orientation of what we're looking at. So this is the right side of a pelvis, looking at the front, and there's your spine, there's your sacrum, just there. This is the ilium. We were talking about all of this last week, so if you're not too sure what those things are, have a look at the bones and bony landmark videos. And then these are some of the ligaments that are over the front part of the sacroiliac joint. So obviously not able to palpate these. These are deep within the abdominal region. You would have to have no abdominal wall and no intestines to be able to palpate these. So good luck with that. And then you can see like these areas here. These are the ones that we're going to be looking at later, because these become quite useful, especially when we're looking at the pelvic floor and when we're looking at the nerves as well. Okay, so the good thing is with a lot of the anatomy in the body, that the structures are named after the bits they attach to, or a region. So if we have a look here, we've got sacrospinous ligament. So if you remember from last week, there was something called the ischial spine, and that was this bony protuberance. There it is, just there. And this is your sacrum. So the sacrospinous ligament goes from the sacrum to the ischial spine. So it's quite useful, that one. And then this one here is sacrotuberous ligament. So you can see that's just tucked behind that sacrospinous one. And this goes from your sacrum, sacro, to the ischial tuberosity. So the tuberous bit. Okay, so, and again, you can see it here. There's your sacrotuberous ligament from the back. Yeah, so it's a posterior ligament, that one. So you can obviously see it from the front in this image, but it's behind the sacrospinous. And what it does, or what these ligaments do, they not perform, what's the word? They create these tunnels. Okay, so we've got this tunnel here, and then this smaller tunnel here, and those will become useful later. So put those in the memory bank for later. We saw this area before, that this is the obturator foramen, and we had a look at that when we was looking at the knee, and some of the nerve supply coming from the hip that supplies the thigh, and this is another useful gap for things to pass through. Okay, so there's no wasted spaces in the body. Yeah, they're all there for a reason. Yeah, and then the interesting thing here, and this is where we can get kind of caught up in a bit of an anatomy trains thing. So this is where the hamstring tendon attaches, and it merges in with the sacrotuberous ligament. And when those first things started to be told to fitness professionals and physiotherapists and massage therapists, it then started to make the body look as if it was connected in a certain pattern. Okay, so there was the hamstrings come up here, and then the sacrotuberous ligament comes across, and then that then attaches into the opposite glute, or and then up into the lat, and then these sling systems and chains were created, and whilst the body moves in a gross way, so that we have patterns of movement, it's not as simple as the hamstring comes up into the sacrotuberous ligament, and then that's the only kind of force transfer for that area. So if you have heard these things before, just be a useful task to just think a little bit more deeply about what they're getting at there. So having done anatomy for a long time and dissecting bodies, you can create pathways, and that pretty much was what happened when the anatomy trains started to come about. Is they looked at the way that the fibers of the body seem to be orientated, and then dissected along those lines. So that's where it all came from. And like we said last week, everybody's slightly different. So there will be anomalies to this, and people will move in and use structures in different ways. So there is force distributed through these connected points, but the anatomy doesn't look like this. That's the problem. Yeah, so this has all been dissected out. There's nothing else here apart from these connective tissue structures. So what would have happened is you get an anatomist where they feel along this border, and they'll go, yep, that feels like ligamentous tissue. So we'll just and usually we don't use scalpels. Use what we call a blunt dissection, where you use your hands just to separate out the tissues. So you'll go in with you're taking away a lot of the other tissue that is around this area, which too would contribute to the dissipation of force, in this case from the hamstrings. So yeah, it's yes, it is all connected, but not in such a specific pattern like is demonstrated in those texts. So and even Tom Myers himself has come out and said he's when he did his original book, the very first anatomy train stuff, didn't really consider the role of the nervous system in the way we move and the way we respond, especially to manual therapy treatment. So yeah, even the people that came up with the original concept have elaborated on that concept. So at the back here as well, we've got posterior sacroiliac ligament just here. So this is the ligament that covers the between the PSIS, so posterior superior iliac spine, and then onto the kind of main body of the sacrum. And then this is a really long ligament, goes all the way up to the base of the skull. It's called the supraspinous ligament. So it's superior to the spinous processes. That's why it's called supraspinous. And it sits on every single spinous process all the way up to the base of the skull. Okay, and then merges into other structures when we get up there. So there's a lot of connective tissue around this area. Obviously, this side is blank, but this is duplicated on this side as well. And then on this posterior view, they've taken off the sacrotuberous ligament, and then you're left with the sacrospinous ligament. Okay, so as it says there, it's deep to this one. So you can't really see it on this image. So they've taken off sacrotuberous, so you can see it there. So it's just obviously the opposite way around to this one, which is a front view. So remember what we were saying last week about the amount of movement that is available in the sacroiliac joint, and palpating this region, having a feel of this region, feeling for movement. So if you've got a couple of degrees, 4 degrees of movement, and then you've got ligamentous tissue on top of that. Okay, so that's your first layer. We've got more to come. Okay, so that these are some of the really strong ligaments that keep our sacroiliac joint still. Yeah, it is a solid structure. Needs to be, because of the forces that are transferring from the ground up through your body when we walk and run. So let's have a little look at those. Here we go. So we've got sacrotuberous, sacrospinous ligaments. Let's have a look at those. Again, these dissection videos are from the Ackland anatomy videos. There's your ischial spine. There's your sacrum. And then look at these holes that the ligaments are creating. So sacrospinous ligament from the sacrum to the ischial spine. Yeah, so that was that bit that we looked at last week. And again, like a lot of the other tissue has been moved away. So that, yeah, there's your sacrum, there's your ischial spine, and then there's the ischial tuberosity, just there, and your sacrotuberous ligament, just there. And again, you can see these gaps that these ligaments are creating. Yeah, so we've got the lesser sciatic foramen and the greater sciatic foramen just here. So the sciatic nerve will pass through that area there. There's some other stuff that passes through the lesser as well. There's your pubis. There is a membrane that covers the obturator foramen. So that gap in near your sit bones where the ischial tuberosity is, it's not just a hole in real life. There is a membrane that sits over it. There's quite a few membranes in the body that kind of fill gaps and divide like front and back or up and down, like the interosseous membrane in the leg. Yeah, so we saw the between the tibia and the fibula, there is a interosseous, so in between the bones, membrane that divides the front part of the leg to the back part of the leg. And we've got a similar membrane here. And so the nerves and the blood supply aren't just flapping around in a massive hole there. That it's all filled with membranous tissue to keep things divided, keep things in place. Okay, so that's more true to life of what it looks like. So you've got a little gap there for the vessels to get through. So we don't really want a big hole in spaces, because then you lack integrity and things can fall through it. Yeah, so we need membranes to keep things in place. So that was a little bit of an overview of those, and then we've got the pubic symphysis at the front. I don't think I've got a video on that one. Let me just have a look. No, I haven't got a video on that one. But it's a piece of connective tissue again at the front of the pelvis. We talked about this last week about pubic symphysis dysfunction. So it's a cartilaginous joint. It's the join, the articulation between the pubic tubercles. So those are the lumpy bits. These bits here and here on the front of on the superior aspect of the pubis. Strengthened by ligaments, wider in women, and then because of certain hormones that are released during pregnancy, there's greater movement in all of the ligaments around the pelvis during that time to allow for childbirth. So yeah, this area here and these structures here, these are all ligamentous. So we've got that pelvic ring. Okay, and then the ligaments at the back and at the front, which allow for some movement of that pelvis. Yeah, so that there is movement, just not very, or shouldn't be too much. Then we've got a view of the inside of the pelvis here. So this is a right side of the pelvis. There's your spine. So that's a lumbar vertebra there. And then we're going down into the sacral vertebra just here. And these bits here, these are called spinous processes. So these are bits that stick out on the back of the lumbar vertebra. We'll do a whole session on that when we get to the spine. This is the inside of your pelvic bone, so the ilium. And then these are the ligaments that connect the sacroiliac joint together. Okay, so the sacrum to the ilium. There's your obturator membrane, and then there's the little gap at the top where the blood vessels and the nerves will pop through. Yeah. So, and again, it won't just be a hole as they pierce through, and that they'll be enveloped as they go through. Yeah. So again, they're not just flapping around in there. There will be. It's a bit like kind of like a what do you call it? That where you put a pipe through something, and then you've got like a rubber connector to push it through, so it stops things leaking. Yeah, that's basically the kind of setup that we've got there. Yeah, so it's all connected in to stop it going through. Sacrospinous ligament, so from the ischial spine onto the sacrum, and then tuberosity just here. So that's your ischial tuberosity onto the sacrum just there. So again, we can see where these holes start to appear here, here, and here, where things can start to travel through. And then if we have a look at this image, this is a lateral view. So we're looking at where the hip socket is, and this is the hip socket just here. So you can see the labrum, right, in there, the acetabulum, which we looked at last week. So that's the actual socket itself. And we're going to have a look at that in a bit more detail today, because there are some specific ligaments. There we go. So there's a ligament called the round ligament. It's got a few names, this one. Ligamentum capitis femoris. That's another name for it. And it's been cut in this particular picture. So it's just in there. I'm going to talk to you about that in a little while. There's the obturator membrane again. So just there with a gap at the top, and then these are your ligaments around the back. So posterior sacroiliac ligaments, sacrotuberous, sacrospinous. Yeah, so hopefully that all makes sense. And then we're on to the ligaments of the hip joint. And if you remember, the hip joint is called the coxal joint. So if you've not heard that term before, And this is the ligament that I was talking about before. So this time, it's the ligament of the head of the femur. Okay, so that rather than capitis, femoris capitis, which is basically what that means. So we've got this little ligament here, and then this is the acetabulum of the pelvis, so the socket part, and then that ligament has got a blood supply coming through it to feed the top part of the head of the femur. How cool is that? Okay, so it gets its blood supply through this ligament just here, and there's an artery from the inside of the pelvis called the obturator artery. Okay, see again, hopefully you can kind of guess where that goes, and then this branch will come off and supply the femoral head. So you can have a condition as a when you're growing up where this either gets injured or doesn't develop properly, and so the blood supply to the head of the femur is interrupted and it doesn't develop. Okay, and they usually notice it when kids start to crawl, start to walk, and they struggle. Okay, so that this is one of the things that they will that they'll check for. But the head of the humerus is supplied by this blood vessel just here. So that's quite an important blood vessel for the femur. And then there's the ligamentum teres, which means the round ligament. Okay, so again, this ligament's got three different names already. Yeah, so well, four, including the English version. So the ligament for the head of the femur, the capitis femoris, the round ligament, and then ligamentum teres. They all are the same thing. Yeah, but they're just given different names. So you can see the ligament just here, and then there's the labrum and the acetabulum of the hip joint itself. So let's have a look at that. Let's get rid of that. Okay, so we're going to have a look at the capsule of the hip in general. So this is the thing that surrounds the whole hip joint. Just pause that there because I've just seen a question. Penny, how could you know if the membrane was causing a restriction? You wouldn't know, and it doesn't really restrict anything there. That membrane. I'm assuming they're talking about the obturator membrane, Penny. Sorry, for some reason the comments aren't loading as I'm going through, so I'm catching them up later. Yeah, it wouldn't really restrict anything. It would. It's meant to stop stuff basically from things from the inside of the pelvis coming out and guiding those vessels through down into the inside of the thigh. So hopefully that makes sense. So this is the capsule of the hip joint. These are all the ligaments of the hip. Yeah. So when we have a look at the pictures in a second on the PowerPoint slides, you'll see that there are specific ligaments and they look like specific bands of tissue. But have a look at this and maybe you can make out some bits, but they're all together. Okay, so they're all linked all together. One thing that's really important, especially for hip dislocations, is the capsules are thinner underneath and it's more flexible underneath. Okay, so remember that for when we look at specific pathologies. So there's the capsule all the way around. It's thick and strong everywhere else. And then if I just pause that there, this is what we see in the textbooks. Okay, these nice, clean, specific structures, and then when you look at that, you're like, well, where is it, guys? Because it just all looks like it's all together. Right, so you would be able to divide them out, of course, but on like a gross anatomy view, it's very hard to distinguish between the different ligaments. So we've got an ischiofemoral ligament that makes up part of the capsule, the hip capsule. So this goes from the ischium to the femur. Okay, makes sense. I'll just play that through. And then we've got, I'll just pause that there, iliofemoral ligament going from the ilium to the femur. Okay, so if you think about where the ischium is, around the back, ischiofemoral has got to be a posterior ligament. The ilium is at the front, so iliofemoral has to be a kind of like anterior and lateral ligament. This is the thickest of all of them, and it's described as like an inverted Y shape. So if we have a look at the picture here, see it's like a Y there, and then come together here. So, but again, have a look in real life. Yeah, it's a little bit harder to distinguish than that. But that's the Y shape just there. It gets tight into hip extension, which makes sense because it's at the front. It attaches all the way around the acetabulum, okay, this capsule, and all the way around the femoral neck. So it envelops the whole thing. And the cool thing is with the capsule is it's where the synovial fluid is produced. So movement of the capsule will help to produce synovial fluid. So it provides the stability for the hip, but also the oil, if you like, for the hip to be able to move. Yeah, we've got different areas of bone where the ligaments will attach to. And if you remember last week, we looked at the different names of some of the different structures. So if something is called a line, then it's quite flat. Okay, so an intertrochanteric line is a flattish line between the trochanters. So this is the greater, and then the lesser is tucked behind there. There is also an intertrochanteric crest, and a crest is where it's raised up a little bit so that it's a little bit higher. So we've don't get confused with the line and the crest. Because you think, well, I thought that was around there, but the crest is raised and the line is quite flat. It's not perfectly flat, but it's less raised than the crest. Okay, so there's the intertrochanteric line just there. Let me just play that through again. So yeah, iliofemoral ligament, ischiofemoral around the back, and then you've got pubofemoral as well, which all make up this hip capsule and comes all the way around. Okay, all around the neck. There's the crest just there, intertrochanteric crest. See how it's raised there, and then there it's quite flat. Yeah, so that's the line just there. Cool. Right, let's have a look at that then. Here we go. So these were the images that we've just seen. So we've got the inverted Y, which is the iliofemoral ligament. You've got the pubofemoral ligament as well. So from the pubis to the femur, again, makes sense of where it is. Must be at the front because the pubis is at the front. So iliofemoral, pubofemoral is more anterior, anterior lateral with the iliofemoral. And then round the back, we've got the ischiofemoral because of the name ischium. It's got to come off the ischial part of the pelvis, which is at the back. Okay, we've also got this one here, zona orbicularis. Anything that's named like that, there's quite a few muscles in the face that are called orbicularis, and it means like orbit, so it goes around something. And I'm doing that because there's one around your mouth, but this one goes around the neck of the femur. Okay, so we've got a ligament that is, sometimes it's called an annular ligament. Again, annual. Yeah, so going all around. However, there are other annular ligaments in the body, so it gets a bit confusing. But this one, zona orbicularis, is what we use for this one. So there is a little slip of ligament just there that wraps around the whole thing. This is useful for revision. Yeah, so screenshot, put this in your notes. And this is where this is what I was talking about with in terms of risk of dislocation because of the laxity. Okay, so all three hip ligaments are lax during flexion. So that's fine. But if you're playing a sport where you get tackled, rugby especially, and your hip is in a flex position as you get landed on by someone who weighs 20 odd stone, you could dislocate your hip, more likely to in that position. So iliofemoral, so from the ilium to the femur. AIIS, remember that from last week? Anterior inferior iliac spine, inferiorly to the intertrochanteric line, which is what we've just seen. So that's where it goes from and to. It resists extension, adduction, and some lateral rotation, provides stability to the hip anteriorly, so at the front. Okay, ischiofemoral this time, so from the ischium to the posterior neck of the femur, and that's what we've just seen, resists adduction and medial rotation, stabilizes the hip posteriorly. And then pubofemoral from the superior ramus of the pubis, so again we covered that last week. So superior is above, ramus is a branch, so this goes from the superior branch of the pubis towards the lesser trochanter. Resists abduction, abduction, with some resistance to lateral rotation, and then we've got anterior inferior stability. But like I said, all three lax during flexion, so that's where the hip joint is most vulnerable. And if you have a look back at some of my shoulder videos, the other ball and socket joint in the body, you will see the massive difference in the size and thickness of these ligaments. Yeah, they are huge in the hip, so provide a real good stability role. Is there a medical reason for the ligaments to be lax during flexion? I think it's literally just for range of motion. Yeah, because if it didn't allow that range into hip flexion, then you wouldn't be able to bring your knees towards your chest. So anatomically, we need it. I mean, if you that's how we squat. Yeah, so you need to go into the loo. So it shouldn't be stiff into flexion. That is just yeah, a little bit of stability sacrificed for mobility in that direction, I would say. Right. Cool. Right. Acetabulum. We looked at this last week. So the acetabulum is called the acetabulum because that is the Latin word for vinegar cup. So acetabulum, the socket of the ball and socket for the hip, looks like a vinegar cup. Apparently, that's apparently what they look like. That's what Google says. And then the labrum is this connective tissue here. Yeah, so all around, and it covers the acetabulum to help to deepen the socket as well. So it doesn't just line it, it also comes out a little bit and surrounds the head. So it creates a bit of like a vacuum, so it stays in position. It's very difficult to dislocate a hip. Okay, so you yeah, but I wouldn't recommend trying it. But it's because of the structures and the ligaments are so solid in that area, and the vacuum that's created by the labrum as well. It's yeah, it's a pretty tough structure. So the labrum, the acetabulum is deepened by the labrum, which is a fibrocartilaginous structure, enhancing stability of the ball and socket joint. And then there is your round ligament, ligamentum teres, head of femur ligament, femoralis capitis. Same ligament, 4 different names, which has got the blood supply that supplies the head of the femur. So that's what that is just there. So let's have a look at this. This is the acetabulum. Okay, so let me just pause that there before they make the femur disappear. So orientation, there's your ASIS, iliac crest, sacrum, anterior part of the sacrum, superior ramus of the pubis, there's your pubic bone. This will be your ischial rami or inferior pubic rami. Then there's the obturator membrane. Yeah, and you can see the little gaps in it for the vessels that are coming through. There's the ligaments that we've just seen. So this is the capsule. And then there's your head well, greater trochanter, head of the femur will be in there. Okay, so this is the top part of the femur, ischial tuberosity just there. So there's your orientation. Let's just have a quick look. So there we go. So that's it without the ligaments and the femur. So there's your labrum. You can see it lining the acetabulum just there. So it comes all the way around, but there is a little hole in the middle there, and it's the smooth surface that the labrum sits on was called the lunate surface, if you remember that. So it's moon shaped, like crescent shaped, hence the name lunate. There we go. So C-shaped lunate surface, and then that's what it looks like on the inside. So we can see we've got the acetabular fossa, which just means like a dip in the acetabulum. There's the labrum all around. Yeah, so you can see that there. And then that bit there, that's your ligamentum teres. Let me just go back a bit. There you go. Just pause that there. Cool. So there's that ligament just there on the head of the femur. And then that's where it is in the pelvis. So that's where your blood supply comes from for the head of the femur. And then there it is. There's the other end, just there. Okay, pretty cool design. So you'll get a blood supply coming through the neck of the femur and also from the socket itself into there. So what that does is it creates a bit of negative pressure. Apologies if you're squeamish with this one. So this is a cadaver. I can't remember where I got this video from. It must be some kind of Instagram thing because of the amount of views that it had. So this is the acetabulum just here. There's the head of the femur. And then there you go. Okay, so that's the kind of negative pressure that it's under. So we'll just watch that again. Apologies if you're having your breakfast. So there's the head of the femur, and then you have to really pull. But then you can see the ligament where it attaches as well, from the acetabulum onto the head of the femur, just there. So the labrum is all around here. So the image quality is not great. But you can make it out, yeah. So there's a lot of negative pressure that helps to maintain the stability of that hip joint as well. Nearly there. Inguinal ligament. We've talked about this as well. Yeah, we've got good for time. I talked about this on when we were looking at the blood supply coming down into the knee, and this is where it all links up now. So we've got the inguinal ligament or inguinal ligament, which comes from the ASIS up here onto the pubic tubercle, yeah. And if we have a look here, we've got this, we've got muscle tissue underneath, and then you've got a nerve, you've got an artery, you've got veins, and then you've also got the lymph nodes coming through that area as well. So this is where your nerve supply and your blood supply will pass underneath to get through to the leg. Yeah, the supply for the ligamentum teres will come off before this, so it'll be in the pelvis itself, and there'll be a little branch that will come through the bone into there. But the femoral artery will drop down, and if you remember, it splits into a couple of different arteries. So we've got a deep one and then a more superficial one, and then they go off and then supply the leg. So this is, that bit there is the only way that the whole of your leg can get blood, yeah, through that part there. There's nerve supply from different bits. Okay, so this is the femoral nerve, but there's an obturator nerve coming through here, and there's a sciatic nerve around the back. So we've got a few networks for the nerves to get through, but blood supply is just there, and that's it. Okay, and then it all feeds back into these points as well through the vein. So yeah, quite an important structure. And as it comes off of there, it forms something called the femoral triangle, and that is this. And again, we did cover this briefly when we looked at the knee, because it involves some of the muscles that cross the knee. So if we remember this one's called sartorius just here, and the inside edge of sartorius is the inside edge of the femoral triangle. The inguinal ligament and the bottom border of that ligament is the top border of the femoral triangle, and then the adductor longus, which is here, the outside edge of that, well, the more medial edge of that, is the other border just there. So those two muscles and that ligament form this triangle, and that is where your femoral nerve, femoral artery, femoral vein, and your lymph nodes are all located in that area there. So this is why, if you are doing treatment around this area here, you don't really want to be pushing too hard on these structures in here, because over the top here is skin, and that's pretty much it. There's nothing else covering that area, so it's quite a vulnerable area of the body. And if you push too hard around here, you can create some compression on the nerve. You can definitely feel a pulse here. Yes, you can, but just by lightly resting your fingers around this area, you can feel the artery. So the artery is quite superficial, and we use that artery in first aid. So if anyone's got a major bleed to the lower leg, you apply pressure here because it's easy to apply pressure there, and it will cut off the blood supply to the whole leg, so they'll stop losing blood. Okay, so useful one to know as well for first aid. And then we had this nerve here, if you remember that one. That was your lateral cutaneous nerve, which supplies the outside of your thigh. So if the outside of your thigh goes numb, there can be compression as it's coming underneath the inguinal ligament just there. Yeah, but that's just outside the femoral triangle. But yeah, that's your femoral triangle just there. And the way to remember it, and sorry, this is going to be emblazoned on your eyes, you won't be able to get rid of it, is this. Why the hell have I got pictures of Y fronts? Well, the way to remember the order is femoral nerve, then the femoral artery, then the femoral vein, then come your Y fronts. Okay, so from the outside to in, that's the order of the structures, and then yeah, if you won't not be able to think about that now. There we go. I've I don't know, either enhanced or ruined your day. So this is the inguinal ligament. Last bit for today, and then we've covered all of the ligaments around the hip and the pelvis. So this will be useful when we start looking at the abdomen and stuff as well. Okay, I'm just going to pause that there. So ASIS, pubic tubercle, greater trochanter, lesser trochanter, ischial tuberosity, obturator membrane, obturator frame, and under there. And then can you see this gap here? Yeah, that's underneath that inguinal ligament. So this area here forms the attachment for the lower part of the abdominal wall. Yeah, so that is a muscle attachment as well, that ligament, as well as dividing the abdominal contents away from the leg. So there's your attachment points, pubic tubercle to ASIS. There's the iliac fossa, and then that's what it looks like just with the skin removed. Okay, so we've got this connective tissue over the top, this superficial fascia, and it's really hard to make out the inguinal ligament. So we've got the external oblique aponeurosis. So an aponeurosis is like a sheet of tissue. External obliques are muscles in the abdominal walls. We'll have a look at those when we get to there. But your inguinal ligament is just there. You can see how everything attaches into it. There's your TFL. But that's what it looks like in real life. So remember when I was talking about the anatomy train stuff, and you go, oh yeah, that sacrotuberous ligament just goes into there and then it goes into there. You've taken away a lot of layers and a lot of other tissue that surrounds it to create this this image of movement patterns. But you can see it's not as clear cut as that. So there's your navy. Okay, so iliacus muscle, psoas muscle, They both join together. So the iliacus comes from up here. Haven't really covered those yet, so apologies if you've not heard of them before. There's your inguinal ligament. Then you've got nerve, artery, vein, and then your Y fronts. Okay, so out to in, that's the order of the structures. And they all pass underneath the inguinal ligament, just there. There you go. Cool. Get rid of that. Pop that on there. Just make sure there's no more questions. They're all looking good. So there you go. There's a connective tissue around the hip. So we looked at the ligaments of the hip, which form then the hip capsule, the ligamentum teres, that one that supplies the head of the femur. What else did we look at? We looked at sacroiliac ligaments, the pubic symphysis, the sacrospinous, sacrotuberous ligaments, and then the inguinal ligament coming across. So that there you go. That's all of those. So these will become really useful as we start to look at a bit more pathology and some of the routes that the muscles take as well. Okay. Hopefully you found that useful. I will see you next Monday, 10 o'clock, and we'll move on to the muscles of the hip. See you then.